So one of the highlights for me at ASCO this year was getting to view and comment on the JAVELIN 100 study. This was a clinical trial in metastatic bladder cancer, urothelial cancer, that randomized patients who had already had a nice response to their platinum or stable disease to receive Avelumab every 2 weeks or best supportive care. This study design is appropriate because typically we do build in a treatment break after a patient has had a nice response to their platinum. And this study really randomized patients to take that break or receive Avelumab up front. But the results were really clear. The switch maintenance approach with Avelumab showed a superior overall survival. And numerically, the median overall survival is the highest we've ever seen in any urothelial cancer trial, even though this is a second-line study. So in my discussion, I really highlighted sort of two practice-changing implications of these data. One is we should be at least more cautious when offering a treatment break after platinum because we have data that starting maintenance checkpoint inhibition earlier helps people live longer. Granted, on a patient-per-patient basis, if we can guarantee subsequent checkpoint, if the break is short, if we're not worried about symptomatic progression, if we're not worried about patients getting ill quickly, those may be patients certainly who could have a break. But the data really support a switch maintenance approach if you can. And the second implication is where we start. So we've typically been testing for PD-L1 in cisplatin-ineligible patients, and in those patients favoring frontline checkpoint. This point I made was more controversial. Not everyone agrees, but I think we can cease doing that and really start recommending carboplatin-based regimens such as CarboGem for cisplatin-ineligible patients as an investment in their improved survival with a checkpoint when they receive it later. Because the data for switch maintenance, again, is really much better than even the frontline data for checkpoint inhibitor alone in cisplatin-ineligible PD-L1 high patients. So personally in my clinic, I will be testing a lot less for PD-L1. I will be starting patients on a cisplatin-based regimen or gem carbo, whichever they're eligible for. After a short number of cycles, I'll be certainly having a conversation about switch maintenance upfront rather than a treatment break.